I think we're out of the way, please. Gonna turn people on and bring it forward on. Yeah, that's all right. Thank you very much. But lovely. So welcome back, everyone. I'm going to go to the finance report and I'm going to Alan.
Very much, Chair. I'll take the paper largely as read. Sort of main highlights is after sort of month 2, we remain on plan, which currently is a deficit of £1.2 million. We expect to be break even by the end of the year. As James alluded to earlier, we're doing well on our efficiency plans so far. We are almost on plan there, only sort of 200k behind plan. From a cash perspective, we are slightly behind where we expect to be for cash, but that's largely a timing difference of needing to pay capital creditors a bit earlier than when we received when we did plan. And our capital plan is slightly behind at the moment. I'll forward to that already.
Obviously, being quite a discussion about it. Earlier this week, I was back earlier this week when
it was Monday.
But sorry, I don't know whether there's anything anybody wants to ask around the financial plan. I suppose I'm just going to make a comment that although we're on delivery, the SIP programme is very challenging and significant numbers. So I don't think we should try to make that sound as just too easy. I'm saying it doesn't sound easy, but I think it is a challenging piece of work for us to deliver. I don't think they're on here, sorry.
Well, just to make comments about one of the things that we discussed, at length on Monday was you see it more clearly in the divisional reports, but even in the exec summary here, clinical revenue is under plan by 1.7 billion, and yet pay is roughly kind of on track with where it's meant to be. And often, if your income is less, it's because you're doing less elective, which we might be given the financial context, but this just seems to have dropped straight to the bottom line. So after 2 months, I think we need to look at the alignment. So is it because we're not releasing budgets, we're holding some back? Or is there we're actually running at a higher pay cost than we budgeted for? I think some of the indicators could do with more detailed analysis to talk about that quite a bit. I think it's worth just highlighting.
I think we all need to make sure those conversations happening a bit publicly.
Yes, because it does. Yeah, absolutely.
I think that's the really wants to come out. Big one spot these first meeting. Moving on. We'll move on to the trust plan.
So there hasn't been too much movement on this just at the moment. We are still in negotiations with our main commissioning ICB at Central East. So once we resolve those negotiations, we'll be able to bring something back.
But even like we just get it. Somebody wants to ask on the plan.
I wouldn't mind a broad if you enjoy with on the kind of timescales. I think Jonathan was not entirely. He didn't feel we were confident we'd get an answer soon. He hoped we would, but he couldn't kind of commit to it. I don't think Jonathan knew what the timescale was.
So I think everybody involved in this wants to try and bring it to conclusion as quickly as possible. I think with the national team, we haven't yet seen that final timetable to be published. So it's still a little bit in the air, which is where we're at. And as soon as we get everything, we will update online.
I think it would be very helpful once it gets it. Yeah, it's a position where we know what we're looking at, particularly because then in terms of the cascading messaging and managing performance with the teams and stuff. I think that takes away that distraction, if you want to call it that, and let's focus on things we and understand what our parameters are that we're working within. Thank you very much. Thanks, Adam. I'll see that wasn't too painful. Okay, I'm going to move on to people and culture, and I think particularly we want to get to ICB. but I'll let you start with item 14 and the workforce update.
Yeah, so so the main part of the workforce update will be sent by Ryan, who's on screen, as simply disability equality standard and race equality standard. And what I want to do though is just draw everyone's attention to a couple of items in the dashboard we hand over to Graham. So first of all, temporary staffing costs, we show it in the dashboard and workforce as a percentage of the pay bill overall. So last week, we look at it in those terms. It continues to reduce, so we're at 8.6% of the pay bill now, which I think is a good testament to the work that people do, particularly around agency work and removing that in agency. We are still stubbornly high as a trust in terms of bank jurisdiction. And we continue to do work looking at that. So we do disability and availability. Some of that work is touched on with the Marshall's report. We'll continue to do that throughout here as well to reduce our reliance bank. I also wanted to touch on the appraisal, as you'll see in the dashboard. As James has talked about, we've seen sustained pressure within the organisation. And with that, there is an impact on things like time to hire, because the manager's shortlisting, things like our appraisal rates. It has now just dipped under the 90%. During the most recent performance reviews, we have picked up the areas where it has dropped in particular, and that's those action plans for how we will be investing in that. And then finally, the sickness absence that you can see there in the dashboard. We've talked about that over the last 12 board meetings. We did show in monthly being 6% for our sickness absence. We've been working really hard with across the organisation to reduce the long-term sickness. In particular, in months for May, so that reduced down to 4.2%, which is the lowest it's been sometimes that we've started to go through.
Any questions, Catherine, on the workforce information? Obviously, 43 to get some flow time dashboard answers. I'll let you carry on letting know what's around and bring it up. Brian, are you able to come in for item 15 for the resident update, please?
Yes, I am. If you bear with me, I've
Can I say welcome to the board?
thank you.
So I'll let you settle in for like four seconds.
Thank you.
I'm not going to go around introducing everybody around because it's difficult anyway when you're looking from online. But obviously you've got all of the execs and the non-execs here in the room. So I'm delighted to welcome you to the board.
Thank you so much. Okay, I have a couple of slides that accompany the wider report. If you bear with me 1 second, let me get it up. Okay, and then you're going to have to tell me if you can see that.
Yes, thank you very much.
Perfect. Okay, perfect. Okay, so I'm going to talk about this year's RES and DES. So if anyone doesn't know, that's our workforce race equality standard and our workforce disability equality standards. They're annual reports that we collect to capture the experiences of our ethnic and disabled staff through a number of key metrics, as well as the staff survey. So firstly, I will kind of cover the RES. On the slide, there's some key highlights of improvements that we've made this year from last year. So we've had workforce representation. So our BAME workforce has increased from 46.1% to 48.5%. That's up from last year. We're also seeing increased representation across most of the bands. So we've seen bands 1 to 4, but also most notably senior bands 8C to very senior management, increase of 7%. BAME staff entering a formal disciplinary is now below parity at 0.91, meaning that BAME staff are slightly less likely than white staff to enter a formal disciplinary process, which is a shift from last year of 1.01. Reported discrimination from peers amongst BAME staff fell from 14.7% to 11.6%. It's still 5 points higher than white staff, but the gap between white and BAME staff is narrowing. Perceptions of equal opportunities has improved for BAME staff from 44.4% to 47%. There is still a gap again between white colleagues and BAME colleagues, but this has narrowed from 15 percentage points to just under 9 percentage points. So we're getting to the point, walking towards parity there. Senior non-clinical levels, so band 8C and very senior management, BAME representation has increased by 7%. There are some gaps still within that data. So the red data shows us some gaps still existing, which is most notably our board representation. So our workforce BAME representation is 48.51%, but our board representation is only 11.76%. And last year it was 17.7%. So something to keep note of and keep an eye of, and work towards increasing that representation. White candidates are still more likely to be appointed from shortlisting, while the score is down from last year. So last year's score was 1.48. This year's score is 1.45. We still have some work to do to get it towards that parity score of 1. And harassment from patients remains higher for BAME staff at 30.46% versus white staff at 26.82%. So some support there that needs to be done. Looking at our workforce disability quality standards, we've seen improvements on people declaring their disabilities. So we've seen more people move from declaring themselves unknown on ESR to declaring if they have a disability or not, have a disability. And that's happened across all bands as well. We've seen disability representation increase most notably in non-clinicals, band 5 to 9, and also at senior clinical levels, so band 8C and above, saw an increase of 8%. Increase in disabled staff representation. The likelihood of disabled staff compared to non-disabled staff entering a formal capability process has remained at 0. So we've had 0 cases showing that disabled staff are more likely to enter a formal capability than a non-disabled staff. But there are still some gaps in there as well. So engagement has widened, meaning that disabled staff are less likely to engage in staff survey results. So last year we had 6.8%, and now it's gone down to 6.5%. So working with the staff network, the ability network, neurodiversity network, to understand why that might have happened. Also, only 34.31% of disabled staff feel that their work is valued in the organisation, against 50.56% of non-disabled staff. So again, trying to work out why that's happening, what we can do to support and drive that increase next year. And also our proportion of workplace adjustments has dropped. So disabled staff feeling as if there's adequate workplace adjustments being implemented for them has dropped from 79.5% to 70.1%. So some areas to keep an eye on. And that is an overall summary on that. Any questions?
Lovely. So Joe's got his hand up, Ryan. Yes.
Ryan, the change in the attitudes or responses in the staff survey for the attitudes of staff members with disabilities was quite stark. Do we have any sense as yet as to why that thought is there, that we don't value or we don't support in such a way? For an organisation that does so well on general staff health and wellbeing and staff benefits, do we have any sense at this stage, or is there a piece of work going on to establish what might be the causes of that?
Yeah, so I'm working with the staff network, so the ability and neurodiversity network, to understand what's going on. A lot of the frustrations that have come out is around workplace adjustments. So as we're seeing staff increase declaring, especially around neurodiversity, there seems to be a level of people not feeling comfortable, understanding what workplace adjustments they want, understanding how that fits within their working life and how to declare that, and what also support there is. So we've worked to train up the network chairs so that they know the process of what workplace adjustments look like, what the staff health and wellbeing team are. So when people come to them and are asking for support, they can adequately signpost. And also I'm rolling out neurodiversity training over the period of July up to October to help staff members, managers improve their understanding of what neurodiversity is and what workplace adjustments might be able to support staff members who are neurodiverse as well. So hopefully all those things, and then combined with the feedback from the network members, we can kind of drive to getting that number higher.
Brilliant, thank you.
And so I just wanted to follow up on that. It's working with the networks. I think there's a couple of things that came out as we built, Graham's just touched on. So the staff passport is around the organisation and how that's used. And it's looking at making that make assistance to its used well, so it really feels a benefit to the organisation. The other item is that for things like reasonable adjustments, historically, so at the beginning they went through discretionary spend money as they do in most organisations. And as any organisation that goes through these processes to scrutinise all the spend, we're still remain with the legacy of that perception, and it still remains there. We've taken it out, don't manipulate those through discretionary spend. But I think what I'm seeing and what we're seeing with staff surveys certainly in the autumn last year is the legacy of that.
And I think, Graham, one of the things we talked about when we meet, isn't it, is this the positivity. Well, Sarah certainly needs to work on the positivity of the incremental shifts in many of these metrics. And I certainly know the way you lead this is that it's not your role to go and handhold people, but to give people the kind of framework of what they're working to, so that we keep shifting the dial. And Catherine's point just there, what something that was a year ago, we'll have moved 12 months. And as we travel forward another 12 months, continuing to make the shifts and help people understand across lots of these pieces, which I think certainly when you come to the Vision Leadership Council, we have really good, vibrant conversations with everybody, including the network leads. Any other questions for me? No, thank you very much for that and for the paper. Thank you. And Catherine, I'll go to you for Freedom to Speak Up report. Have you looked at I'm going to you? I can't see anybody online. Yeah. It's interesting. Okay.
It's 8 foot square.
Yes, sorry. Kate, I'm going to you, I think.
You are, thank you. So this is the Q4 update for Freedom to Speak Up, which Amna Shah, our Freedom to Speak Up Guardian, has compiled. So this will have been through People and Culture Committee, which Amna attends independently. So hopefully it sort of speaks for itself. I think one of our areas to watch really is around resourcing for the Guardian role. So obviously Freedom to Speak Up always comes up very strongly in external reports. So again, if you're referencing back to Ockenden and the Baroness Amos review around the importance of being able to raise concerns and issues within organisations. So Amna does a huge amount of work across the organisation, supportive work, working closely with HR, working closely with Ryan in different areas, and also within sort of the kind of more sort of purist Guardian role. We've also got some guardians, some champions and part-time guardians who support Amna in that work. But we will look at how do we resource that more effectively on a long-term, on a sort of longer-term basis, sustainable basis, to make sure we've got the right resource in the right place. Otherwise, the report hopefully speaks for itself in terms of number of reports that through this quarter and how that compares quarter on quarter. Some of the themes that are coming through, you know, our sort of most, I suppose, our most our theme that we are focusing on in both in terms of Freedom to Speak Up and in terms of other reporting that we see elsewhere in the organisation, so through incidents, for example, through staff survey, is around that theme of incivility, so the impact of incivility in the organisation and how we might combat that, again, through in all sorts of different ways, not only through Freedom to Speak Up, but as a theme through the organisation. And then you can see in quarter four as well, there was a sort of more dominant theme around system and process. This report doesn't really drill down into what that means. So we do need to do a bit of work around understanding what system and process and where and why that's having an impact in how people feel about where they work and how they work. Obviously, we've got some summary reports as well around how reports are raised. So whether they're raised openly with people's names, confidentially or anonymously, and you can see the data in there. So open 12, confidential 14, anonymous only 1, and we obviously want to encourage people to feel safe in speaking up and to not be concerned about suffering detriment if they speak up, which is a continuing area of work for us as well, to give people the confidence in speaking up in a named way so that we can work together with them and in the place that they work to resolve their concerns. In terms of concerns related to a protected characteristic, I think that the table there again speaks for itself. The numbers are small, but in Q5 we had the highest number where race was named as part of the concern raised, so relating to race. So that's something that we will do some more in-depth work on to understand both where those concerns were raised, why they were raised, and what we're going to do about them, linking in with Rayanne and the anti-racism work that is being led through Rayanne and her team. But happy to take any questions.
It's not a question, it's a comment.
Oh, sorry. Yes,
It's like, it's more a comment around the reporting. You know, there's anonymity, but there's also accessibility. And I think one of the issues or one of the areas that we talked about, people and culture, was the fact that, you know, making it accessible for people to report and actually highlighting the areas where people can report. So, you know, boxes being put in strategic spaces within the hospital so that people have got access to report in a manner that gives them the confidence for confidentiality, but also the ability to work in media.
Myself, to meet Joe, to Catherine, got you a culture that we definitely want to be having the voice heard. And I think to be surrounding instability for me sits with our earlier conversations around things different subjects when we're talking about compassionate organisation. I think we want a kind, compassionate, civil organisation where everybody respects each other. So it's something we will continue to work.
I think another area, sorry, that when we talked about systems and processes, that was very much linked to recruitment internally and culture, previous culture shift, which is obviously an area of not concern, but an area of focus in terms of changing the shift of mindset in terms of, you know, are there fair practices of value-based recruitment now as part of that, but some area that, you know, in challenging those systems and processes, there are elements that we are looking to bring those initiatives through those that gap.
I shall move on. And thank you very much, Kate. And takes to the nursing workforce update.
Thank you. I'll treat the papers read and bring out some key points. There is a continuing improvement in the trust nursing and midwifery workforce position. If you look at the table, the graph facing safer staffing report, there's progress in the workforce utilization, despite sometimes you know to see it fluctuates, but we could see that, you know, upward trend or downward trend would give some indication that there is focused work to address that. And that's also reflecting in the registered nurses field rates, the temporary staffing reduction, and the key patient safety indicators, despite ongoing operational pressures and periods of political for escalation. Overall, the workforce utilization has reduced to 101%, representing a continued positive trajectory and improved alignment between staffing and patient need. Registered nurse fill rates continue to strengthen and reliance on agency staff has reduced, supported by increased use of NHS professionals and target workforce initiatives. The triangulation of staffing data with quality outcomes provides assurance that improvements in workforce stability are translating into positive patient outcomes. Falls and medication errors, we've seen reduced month-on-month. Red flags and staffing related to radar incidents continue to decline, and robust governance arrangements are in place to identify escalate and mitigate staffing risk. I'll pull out here while pressure also reporting has increased. This is being closely monitored through established quality governance, and I'll probably just expound on that because Joe alluded that I will expand on here. The next steps on the back of this staffing report is to overlay the quality indicators to just fully understand the wider picture. So if I level in, because I think pressure also has been quite a topical point, it's not just looking at the data high level like that, it's getting behind it. So we talk about the pathway front of house, the timeliness if we don't assess the patient within 4 hours, but also looking at the care pathway when they're an inpatient. Are the equipment that they're using, are we using them effectively? Are they having timely care? Are we adhering to care plans? So that's staffing bit overlay. And I think from one of our other internal meetings, Catherine, we had a conversation around the staff survey. How do we overlay that? So that would give us true picture over time as to what the organization is looking like. And then when we pull on the further data sources we have, such as our water accreditation program, our self-assessment audits, our peer review audits, it will give us real focus onto direction of travel as to where we go. So if I pick back the report up to say, you know, the board can also take assurance from the significant work underway to strengthen workforce sustainability and professional governance. And this includes the completion of biennial establishment reviews. I believe that may be coming to next board. Implementation of the enhanced therapeutic observation and care improvement program, of which we've had positive feedback on our progress, and development of trust-wide violence aggression toolkit, where we had a nurse who had led on that project over time, and we've seen the impact. So we look forward to see what the toolkit and implementation of that, and the advancement of advanced practice governance arrangements and progression of the nursing and midwifery job evaluation program that's underway. In addition, a new multidisciplinary NMC-HCPC panel is being established to ensure consistent and transparent professional regulatory decision making, because we are all aware of the national guides around the nursing and midwifery councils to make sure our internal governance are compliant. So whilst challenges remain in some areas, particularly relating to healthcare support workers, vacancies, enhanced observations, and variation in ward level staffing pressures, the overall position demonstrates a more resilient nursing workforce following the investment and the establishment review in alignment with the National Quality Board. And that demonstrates an improved staffing stability, strengthened governance oversight, and collectively these developments provide assurance that the sustainability in line with the national workforce safeguards and quality standards. So from an assurance perspective, I can summarize by saying the trust has effective systems and processes in place to provide oversight to nursing and midwifery staffing, quality and patient safety based on what I've shared as the next steps. Current data demonstrates improving workforce stability, reduced reliance on temporary staffing, strengthening workforce governance, and positive trends in several key patient safety metrics. Our senior nursing leaders maintain continuous oversight of staffing risk through established escalation processes and ensuring that safe, high quality care continues to be delivered to our patients despite ongoing operational pressures.
Marshall, there's obviously a lot of journey in the last 12 months in the last 24 months. What do you think two key things out of all of the things you described there are that's made the biggest difference over 12 months time frame?
I do believe that the two key things, it's about how the first thing I'd probably ideally putting it in a culture setting. It's really stimulating staff around the importance of how we continue to maintain standards. And the second one, I would say the investment in the establishment to really get us to where we need to get to. So those would be the two key things. You didn't ask me about the next step. It's how we then shift the dial in really wanting to see the return on investment. So conversations would be shifting, how we drive improvement, how we demonstrate assurance. And that would involve some accountability conversations. Yes.
So I think it's important for the board to absolutely recognise that this provides some assurance around nursing safety, quality. I think what Marcia was helpfully identifying was it is only some assurance. I don't think we have. I think there's some real opportunities to understand where the variation in our quality and safety of care is taking place. I think this report starts to get into some of that. And we need to be sitting around this table understanding that we have got warranted variation in wards X, Y, and Z. There may be potential unwarranted variation in wards A, B, and C, and this is what we're doing about it as an organisation. So I think this is a reflection of where we've been. I think the next stage then is to get into the from where do we go on next. I think it's really helpful.
I'm sure with the ETOL, we'll have to work that. So there'll be improvement plans in the outreach, you know, as COVID feels very particular with things, and you can see how much and what you need from the organisation for us to support.
So we talk. So it's part of a national QI project. So we do get that national support, and we've had feedback recently, which was we were quite content with, which was positive. We now know the areas that we need to progress, and it's that bit with the biennial establishment review is not looking for further investment. It's about how we realign our existing budgets within the different wards. Regarding reporting, there's an ETOP rule, and then that feeds out externally, but our governance that feeds into a strategic advisory group. And also you would see elements of that come through as an update to the CNO report. So that's where, and that comes through to patient safety board as well. So that's where we're doing the monitoring of that. And just for further context, the ETOP group brings in dementia into that conversation. So it doesn't mean that there's silo working, there's collaborative working equally while we are able to meet the other standards within those domains. Wow.
Thank you very much. I'll move on to our team. I think great responsibility support. I think I'm looking at.
You coming to me, Heidi? Sorry, it's not, I can't hear very well.
Sorry, yes, please. Sorry, we're moving to item 18.
Great, thank you. So this is just an exception report for the board. So it's not our sort of full reporting month for these various different areas. So they're just they are just here by way of update. So I'm not going to spend a huge amount of time going through each of them. The risk management report is hopefully sort of relatively self-explanatory, and our usual work goes on around sort of risk housekeeping. Litigation, I won't go through the report. It's a very brief report around the normal matters that we discuss at boards, so inquest updates, updates where things haven't actually gone to inquest because we've been able to provide good assurance around actions taken from events, and manage family concerns through other processes, which is positive. We've also discussed at Quality and Clinical Risk Committee how we interface with between litigation and PSEF investigation. So there's an SOP that has been developed for that to help guide us in that, in making sure that the information we provide to the coroner is sufficient for his purposes. In QI, there's a lot of activity which you'll hopefully be able to see in the report in quality improvement. So the team are working very hard across quality improvement areas, and some of them are captured on here. And there's a brief update in the report against each of those main quality improvement project areas. So things like Martha's Rule, dysphagia, discharge processes, which is an increasing kind of area of focus around improvement. And there's also been some good sort of measurable improvement in audit engagement. So that is again positive. Patient experience, it's, as I always say, it's a nice report. It's a nice report to read. Lots of engagement work going on across the organisation. We've also been working to do things like taking forward the ward and trolley service. Now the Friends have left the organisation so that we continue that that service and support for patients. And then in complaints and PALs, you know, again, you can see the sort of story through complaints and PALs is one of increasing volume, which has been the same story throughout this year. So we are seeing more complaints in terms of volume. We are seeing complaints moving, you know, into the sort of often moving into the sort of more complex space, which I've talked about before. We have got QI colleagues working alongside us in complaints to look at thematic areas, and you know, both in terms of areas of high volume for complaints, but also the themes around complaints. We're doing some work in our radar system, which is a system that we use for almost everything in terms of incident reporting, audit capture, complaints management, etc., litigation management, to align all of our reporting categories so that we can get one single lens in that says the same thing, or asks the same question rather, for different areas, so that we align our categories for reporting and complaints, for example, so that we can get a good look into what's going on across safety and experience, for example, in individual areas. At the moment, they're slightly different, which doesn't help us, particularly to get a good kind of focus in different areas. But I'm happy to take any questions. I know it's a sort of a report that kind of jumps about a little bit, and we are, as I've described, working on a different report as a sort of dashboard-led report aligned to the Care Quality Commission's quality standards, which will present this slightly differently in the future.
I just want to keep nosy, Kate, you said it, but the increase in complaints and the increase in complexity, because I think that certainly when you're behind the scenes and you see some of that absorbing people's time in terms of that complexity, I think you just need to keep being aware of that. And as you kind of voice there, whether there are ways of us operating to some of those, responding to some of those, but in a more efficient way, but they're complex, they need individual attention. And I think the board should just be aware that if you take up considerable time, people run this table, but people across the organisation. Nothing else to play there. No. Thank you very much, Kate. I'm staying with you, I think, for the modern slavery and human trafficking statement.
Yes, hopefully this is a very straightforward matter for the board, and we are required to have a published statement on modern slavery and human trafficking. So we align that with NHS England's requirements, which are set out, and we have to link to their report. But obviously we're required to do due diligence through our own policies and procurement networks to make sure that we are doing everything that we can to ensure that we are a part of the whole government effort around tackling modern slavery and human trafficking. So that is this document sets out that commitment from us as a board, and we are asked to approve it, please, today.
Approval for this, chance that involves around the table. So that is approved, Kate. Thank you very much. That brings on to the chaplaincy annual report.
Yes, thank you very much. Staying with me for this as well. So I'm aware the board probably don't hear a huge amount from the chaplaincy throughout the kind of board programme in the year. So this annual report is a nice moment to be able to reflect on the incredible work that they do as a very small team supporting both staff and patients across the hospital. The annual report reflects that work and talks about the team and what they do in the time that they have in the organisation. They support both our organisation, they work across Willen Hospice and providing support to the hospice, and also to CNWL and providing support to patients in CNWL as well as staff as needed. The chaplaincy has a head of chaplaincy, Sarah Crane, and we're currently recruiting for a chaplain to replace a colleague who left to go to a different role in a different organisation. And we also have a network of volunteers for pastoral care and pastoral support, and also chaplains and faith leaders from other faiths who come in and support our patients and our staff. Sarah Crane, our lead chaplain, who's also the chair of the UK's Health Chaplaincy Board, works across the interfaith networks in Milton Keynes and beyond, and so we have a lot of support and positive networks in place to be able to provide really, really good support and services for our patients and also our colleagues. hopefully, again, this report is fairly self-explanatory. I think, I mean, the number of patients and patient visits and support hours that go in to both patients and staff from chaplaincy is really significant. They work incredibly hard. They provide a service that I think hopefully anyone you would speak to who's accessed their service speaks very, very highly of. And they are a very committed, passionate group of people who provide very expert care across all sorts of different parts of the organisation, and work very closely with almost every team in the hospital. So I think I just want to commend them, actually, a small team delivering a hugely impactful and important service, both for our patients and for our staff. But happy to take any questions.
Okay, this paper is been waiting. I'll give my thanks as well to the chaplaincy team. Don't I'm seeing any questions here, so thank you for the paper.
Thank you.
And I'm going to move us on to item 21, the risk management report.
Yes, thank you. The risk management report, again here as it would normally be, with some items just sort of regular items around. Obviously, we keep a close eye, and we're constantly working around overdue risks. And we talked about compliance and the importance of compliance earlier on in the meeting. That work continues, and Paul leads that work very effectively. We are still working around the final sort of approval process to look at a different training package for risk and health and safety. So that's just working its way through the organisation. Otherwise, this is here for information for the board and for any questions the board may have.
Thank you, Kate. I'm not seeing any hands up. I might be conflating papers here. In terms of moving on to radar and moving paper formats, was there one particular area which has a significant, was it pathology that had a significant workload to move on to radar? And all my questions are going to be is if there is an area which has a bulk of the workload to be moving across, moving their risk assessments onto radar, then you might need to look at some form of support for that team.
Yeah, that's right. Yeah. So we'll take that. So it's important from our perspective to have a sort of robust electronic system of risk assessments. But yes, obviously we'll work with pathology. There's highly regulated areas, particularly pathology being one of them, and there are others as well. A lot of them sit in core clinical, actually. They will need some support to enable them to do that effectively, and not to monopolise, all of their administrative time in doing that piece of work. So yes, we'll do that sensibly.
Lovely, thank you very much. It's very helpful to know. I'll move on, staying with you, to the board assurance framework.
Yeah, so the board assurance framework, again, hopefully self-explanatory. There's a risk that I think has probably come from John, which I think has sneaked onto the board assurance framework, which I might dispute outside this meeting around roadworks and disruption. I think it probably is a corporate risk, but perhaps not one for the board assurance framework. But I note that it's gone on to the board assurance framework. It will doubtless have an impact, but I think it's probably one better managed through the corporate risk register. But I will pick that up with Paul outside, and we will have we will see where that's come from and whether it needs to stay on the board assurance framework or not. But otherwise, it continues as a rolling update. It's updated every month, and there will be further updates to come on the board assurance framework month to month.
I'm glad you said that about 797, because I was not sure about that, so you'll leave that with yourselves to discuss. Got a couple of hands going up. I am just going to ask one question, which is on the 616 and the 617, which is that's been a significant update. I can't see the update in the document.
616 has gone down.
Yes,
But the other one
hasn't. So I was getting a bit confused about what the significant update was, but again, James might have said something.
Yeah, so I'm the accountable owner for both of these and reviewed from coming in. 616 has gone down because reviewing the risk, our planned care was previously around the harm that would almost immediately happen to patients with some of the sort of delays in performance. Looking at the system and process we have in place about harm, with clinical harm reviews and others, as well as the improvement of our performance to where it is now, at 6%, very much in line with others in the NHS. I was assured that we are not at the most severe levels of harm and that happening regularly, so recommended we reduce that score. It has also been framed slightly, the wording ever so slightly differently, looking at more of a sort of ongoing recovery rather than where we have been really
it's the wording I could see, but I was not sure that that's right.
on the emergency demand, that hasn't changed, because, but it is sort of framed in some of the wording detail. I was just trying to bring in some of the rounding effects. The difference between the two is the emergency department can go wrong on the same day and cause harm. So there is an immediacy to that, as opposed to planned care, where we do get any time to see things going, and actually that's sustained performance improvement. We want to keep them.
Just quickly for me, I realised in reading this, I didn't fully understand what inherent risk meant. But there's target, natural. What does inherent mean?
So the inherent risk is the risk as it's first graded.
As it's first graded.
Yeah.
Yes.
It's the unadjusted gross risk.
Changes and adjustments put in place. Now, any mitigations in place.
So it should be higher than where we are.
Yes.
Yes.
So inherent 20, there are some mitigations, so that brings to 25, some mitigations, then bring it down to 20. Gross adjusted.
Any other questions? I'm so sorry.
No, it's all right. Okay, I think partly because I'm now become chair of audit committee, but I think possibly we could do with seeing the framing of some of these, because the emergency aid is always a risk. Yeah, of course it is. Planned care is always a risk. Yes, somebody might come to harm while they're waiting. And actually, so I'll take some time, maybe talk to James, maybe talk to you, Kate, about how we frame and present these. And some of these take the same for a very long time.
I agree. Yeah.
Some of them that's right, some of them maybe is so I'll just float on that and some of it with you guys.
Thank you.
No further questions there, I think, based on the board assurance framework. So I'm going to move on to item 23, which is the board committee assurance reports. They're there for obviously people to have read them. So I've had the audit and risk committee. David wants to like his comments on that one. The finance and investment committee, which again we've spent time on finance today. I don't think there's any comments to make there. And the quality and clinical risk committee. But not so questions for staff. So thank you much. We take those on note those. And I'm going to move on by for use of the corporate seal case.
Yes, thank you. Just here to be ratified and for transparency, where the corporate seal has been used on documents. So it always comes to the board for transparency and just to ratify those decisions.
Noting the use of the corporate seal, and there are questions. Thank you. That moves us on to the forward agenda planner. I think we're going to keep reviewing the forward agenda planner. It remains on the acting board, in particular as we're looking about how we're going to talk to ourselves about our integrated report, so we'll be able to do that. I think if we've got any questions, I don't think I have any questions from those of you yet. No, thank you very much. I just want to say, in terms of time that we spent in the early part of the meeting on patient safety and around patient experience and performance, I thought they were helpful conversations. And then I thought we spent appropriate time, particularly in the residents. It's very good to have Rayanne on board, but also we've noted the further papers, do things like the nursing workforce update, which I think we helped the board to gain assurance on where we are. And as long as we are happy that we're there, I'm going to close the meeting. So thank you very much, everybody, and thank you to those members who are on the line. I'm closing the meeting. Thank you very much. So we are at 1:15. So shall we have half an hour lunch?